Hi, I'm Rosemary Clee, the Executive Director for the Bergen-Newbridge Medical Center Foundation, New Jersey's largest not-for-profit hospital, and the sponsor of In the Know with Ro, an informative conversation with leading clinicians on important health topics. Today, I'm joined by Dr. Hannah, who is a physician specializing in physiatry here at Bergen-Newbridge Medical Center. Her clinical interests include all aspects of general musculoskeletal pain complaints, ultrasound-guided musculoskeletal procedures. She is board certified by the American Board of Physical Medicine and Rehabilitation. Welcome, Dr. Hannah.
Thank you, Rosemary.
Chronic pain changes lives. It impacts self-image, affects others, and interrupts plans. It's a disease that sometimes the person with doesn't understand and others don't accept. Being bedridden one day, but unimpaired the next, can be difficult to explain to others. It's normal to feel angry when pain hinders from your activities you enjoy or the ability to take part in routine tasks. Dr. Hannah today will help us navigate this difficult terrain. She'll offer some simple solutions to manage chronic pain. So what is chronic pain, Dr. Hannah?
So I think it's a good leeway first to identify what's not chronic pain, so for patients to help know or identify what is chronic pain. So pain, we normally divide it into two sets, which is acute and chronic. Acute, I think the best way to think of it is an athlete on the field. Ankle sprain, knee sprain, shoulder sprain if you fell on your shoulder. So acute pain normally lasts for a few days up to a few weeks, and it's normally managed by what we call RICE. So R stands for rest, I stands for basically the anti-inflammatory part of it. C is compression, and E is elevation. So basically rest and modalities such as anti-inflammatories. Now, normally it's self-limiting and resolves with time. Chronic pain is pain that exceeds a period normally of 3 to 6 months. We identify that as being subacute, and true chronic pain is above 6 months. It is pain that normally is not self-limiting, that is not managed by the regular conservative management that we can potentially do at home, like we discussed before, the rest, elevation, compression. So that's probably, I think, the biggest difference between the two is the time frame, and also in terms of the intervention is different. Chronic pain may need more imaging modalities. You may need to go for an MRI, X-ray, additional diagnostic studies. It also may need more than just medication management. You may want, injections versus surgery. And also with chronic pain, I think the biggest thing we need to rule out is any underlying malignant or infection etiology or causes of pain, and then we normally go on from there.
Okay. So what's the different type of pain complaints that you see as a pain specialist?
Low back is very common. Shoulder pathology is very, very common in patients. Knee pain, very common, along with hand pain, which is patient normally would say it's we call it the carpal tunnel, but the numbness and tingling, especially in our blue collar workers or even desk jobs, it tends to cause the compression of the nerves in the wrist area. These are probably the biggest highlights, and I feel a lot of times patient would say, well, you know what, I was never in any pain all my life, and all it took was a simple movement such as taking garbage out of the garbage can, or I just twisted a certain way and my pain just came on. And I'll tell you, of course, after ruling out big red flag things like any malignancy or any infection, a lot of times there is already underlying arthritic changes that gets exacerbated by motion. So what I'm trying to say is above normally in all of us human beings, once we hit the age of 30, 35 and above, we tend to develop some form of arthritis. Arthritis normally is really what it is. It's bony enlargement in major joints, like your shoulder, knees, hips, lower back. It's our body's way of trying to support our weight, just trying to support the activities that we do, And it's normal part, even though at the age of 30, 35, and 40, 50s, your middle age, as in the aging process, it's just natural progression of the body. Pain is not. So a lot of times it's that certain movement that exacerbates what's already there from the beginning. So that's what I would say the major, body parts that we deal with. And a lot of times, of course, it's because it just got exacerbated, because you also have to remember, on top of that bone that is arthritic or enlarged is the muscles, the tendons, the ligaments that tends to get irritated from that bony enlargement. It tends to put the muscle into spasm, if you want to look at it that way.
Okay. So, can you give us some examples on the different types of bodies that you mentioned, whether it's ankle, and the strains that can happen with, the day-to-day stuff like carpal tunnel or severe, pain in your knee?
Yep. So the knee, I feel it's very common, what we see, and normally patients would say, I hear clicking or cracking in my knee. Going up and down the stairs tend to cause significant discomfort and prolonged walking. So that's very classic of the knee arthritis. Now, when we first see the patient in the clinic, we normally would get an x-ray, always a baseline x-ray, just to look at the integrity of the bone. We do also have ultrasound in the clinic that we normally just scan the knee to see if there's any fluid, any signs of irritation, or anything, a red flag sign, for example, any inflammation in the knee that would warrant me to get an MRI or further workup, diagnostic blood workup. From there, I would say, we go on to therapy. So modalities that normally help with that chronic pain is definitely physical therapy, because in therapy, patient can partake in managing their pain by being proactive, and also, following the therapist's recommendations. So it's something that you're not receiving passive treatment. It's both passive and active. In terms of therapy, they do stretching activities, heating modalities, but they also teach the patients exercises that they're able to perform at home to better improve their condition, to strengthen the muscles. When you actually strengthen your muscle, especially, for example, in the knee, like your quads and your calf muscles, you actually take off pressure from the joint, from the knee joint itself. So the muscles in this circumstance would aid in taking off pressure from that bony grinding that patients will normally describe. The grinding that they normally hear, or the clicking. Normally, the bone in the knee is made up of, a few bones joined together into the knee joint. Between each bone, or when bones basically coincide together, there is the cartilage, which is almost, I always say to patients, it's almost like a cushion, like a pillow, kind of. It's almost like a shock absorber, so that when you go up and down the stairs or walk, it basically almost like a spring, so that it takes off pressure. Now, with arthritis, as the bone enlarges, what ends up happening is that the cartilage gets worn out. Okay, that cushion tends to thin. When you thin, you're creating more and more less lubrication and cushion space between the bones, so the bones become more in contact together, versus of them having good space between each other, so that you don't feel that grinding or clicking. So that's with arthritis. So so it's a lot of pressure, especially our body weight. No matter what your weight is, the knee is a major weight-bearing joint. So in therapy, and a lot of times, even if you do work out, a lot of times we don't pay particular attention to specific exercises, to specific muscle groups that will help alleviate some of that pain. Now, if patients, in the case of knee osteoarthritis, fail therapy, meaning they do not have long-lasting benefit. A lot of times you feel very good when you go to therapy, because you have modalities and you have the stretching. Long-lasting for me is when you finish therapy, you're able to perform the home exercise independently and be pain-free. That's when you say, you know what, I'm 1 month, 2 months out of therapy, and I feel great. That's very good. Others would say, you know what, I felt great while I was in therapy, but then pain just went back to baseline. That's when we try to do more intervention, be it intra-articular cortisone injections, which basically cortisone is a very potent, strong anti-inflammatory to calm down, because with arthritis also, I want patients to take a look at it as being a cascade, where a lot of times you have no pain, and all it takes is that simple movement, and then your pain just escalates up. Some patients are able to come back down and no problem, pain-free again. Other patients are stuck, like they end up being stuck at that peak. We can bring you down from that peak of pain by therapy. If not, then by the cortisone injections to calm down the inflammation. And down the line, you do what's called viscosupplementation series injections. What they are is they're gel injections in the knee to stimulate the lubrication that's supposed to be there naturally, but is depleted when arthritis hits. And a lot of patients do very well with it. Last resort for knee, and it's also part of modern interventional medicine. It's been there since 2011 with a large study that was done in Korea, where they basically ablated, it's called radiofrequency ablation of the knee joint. What they did was, in patients that were not candidate for surgery, patients that, for example, they are due to health issues, due to being on anticoagulation, or they desire not to have knee surgery, what we do is we ablate, we apply heat to the nerves in the knee joint that supply sensation to the knee and convey signals to your brain saying, hey, you have arthritis, you have pain. We try to shut them down for a duration of 6 to 12 months. By applying heat under, of course, it normally is done in the operating room, not that it's a surgery, but we do it very sterilely. And we also are very careful not to come near the motor joints, motor nerves, which basically supply strength to your muscle. It's just the sensory nerves that we affect to basically numb down those nerves for some time. And we've had excellent progress with it. Patients are normally pain-free for up to a year. When you're pain-free, you're also able to, so my goal is, if you're in pain, I'm able to control your pain, you're going to go to therapy, because when you're pain-free, you actually will be able to participate fully in therapy. Therapy will not be a waste of your time, and you're going to reap the benefits. Even if pain comes back again, normally it doesn't come back to its baseline because you've already took measures to control it while you're in that pain-free period. That's for knee. We do actually very similar modality or interventional to the back. So the back, we do same idea. We always are very conservative in our management. We never ever will jump to the thought of doing injection right away. At the end of the day, we want to improve quality of life and make it long lasting. And we always give the patient the most conservative route because if conservative management helps, why would I want to do something more invasive? What we end up doing in the back, again, therapy. A lot of times patient would have that sciatica shooting pain down the leg. For that, we do epidural if it's resistant to therapy and medication. In the back also for arthritis, which is very, very common, we do also, it's called radiofrequency ablation of the joints in the lower back, where we actually do this. It's the same idea as the knee, but we carry it out in the back. And again, it's to stop the sensory nerve from sending almost like a telephone signal to your brain saying, hey, you have arthritis, you have pain. You try to shut down that signal for some time so that you're again able to resume normal life. Normal life in the sense of also going to therapy. Because, the last thing I would want is a patient that's walking with a walker or a cane or on a wheelchair to send them to therapy. I don't think they'll reap any benefit. I think these are the major things. And lastly, I think what we see is shoulder, also very, very common. Even in young population, a lot of times, not only is there arthritis in the shoulder, a lot of it is actually what we call, and you may have heard this with athletes, rotator cuff tear, where there are, what's a rotator cuff? Rotator cuff are the tendons. And tendons, to simplify it, and I think it helps sometimes to have a visual, it's almost like a string that attach the muscles in the arm to the bones. So the string, you want to look at it as being a telephone cord again, or a wire. When you have the wire very well insulated, it works perfect, and you're able to move your shoulder in all planes, no problem. When that wire starts to have a little bit of, tears here and there, and, a little bit of nicks here and there, that's when you start to have what's called tendinosis. And patients will tell you, I can't even brush my hair, or I can't shower. I can't literally put my arm above my head. That's called impingement syndrome. For that, we also do therapy, but a lot of times I see most of my patients come and they're already we call it frozen shoulder, where the term frozen shoulder is actually rightly so, because they come in and the minute you move their shoulder this way, they say, stop, doc, I can't, I'm in so much pain. So somebody who's able to move that much of their shoulder probably will not be able to go to therapy. They will be in so much pain that therapy will not be beneficial in the beginning. Eventually, we send them to therapy because long-term management is therapy along with injections. So for that, we do joint injections with cortisone and nerve blocks, because there are nerves here also in the shoulder, from the neck that innervate your shoulder, that we also try to block to offer them that pain-free range period. Hip is also a very common complaint, especially in young athletes, construction workers, and the common thing with hip patients will say, I have trouble putting on my shoes, like crossing my legs, putting on my shoes, or getting in and out of the car. And they'll always say it's my groin, and that's normally hip osteoarthritis. So these are the common things we see. And for the hip, there's also similar injections even to the knee and to the back, where we do inject the cortisone. A lot of times we also, and I think part of what really makes it stand out is we are very cautious in the amount of cortisone we give to our patients. At the end of the day, when we have a patient, we also look at their medical history. Patients are not just, I think a good interventionalist is someone who keeps track of all the injections that the patient had, to see how much steroid or how many or what type of interventions they've had, and had they had any benefit with it. It's pointless to do steroid injections in the same joint, for example, in the shoulder, 5-6 times, and patients have no benefit. So why would you repeat it? Because remember, also cortisone does have a cumulative effect. Where it does, your body absorbs, even though a very minute amount, it does make a difference, especially in diabetic patients. We also have to watch that blood sugar when we give cortisone. So that's why we have the other modalities, like the gel injections, viscous supplementation series, and we have the radiofrequency ablation, which does not involve any cortisone. So these, I would say, are the common complaints that we have.
So you talked about different ways of taking care of, the pain in the office. But is it okay to take Motrin and Advil, or even leftover opioids that was prescribed for something else, to manage that pain?
That's an excellent question, because we also do, day in and day out. So remember I spoke about the acute pain, acute sprain? Mm-hmm. Absolutely fine to take anti-inflammatory, like over-the-counter Advil, over-the-counter Aleve, only for a few days. I normally would say, take 1 to 2 tablets, no more than 4 to 5 days. In the long term, anti-inflammatories also have their side effects. The biggest things are stomach irritation with patients who had acid reflux, kidney problems, especially if you have any renal impairments and you're diabetic. You want to watch that kidney and not overload it with anti-inflammatories. Heart conditions also could exacerbate heart conditions. So we're very, very cautious, even in patients with acute pain, that we see in the amount of the anti-inflammatory that we tell them to take. And it's, again, over the counter. So in acute pain, yes. In chronic pain, a lot of times it does not do any benefit, because you get the patients who's been in pain for a whole year. They've been literally taking NSAIDs for a whole year, and that's a big no-no, because you'll find that their kidney function levels could be a little bit elevated. Their blood, their stomach, they never had acid reflux. Now they have acid reflux because of the amount. It's almost like burning burning in layman's language, but you literally are irritating the walls of your stomach. So for chronic pain, I would say, remember, chronic pain, the way it started was acute pain. So if you take it for acute pain a few days or even a week, and it doesn't really help, then you have to move on forward to other things outside the box. So yes, for acute pain for only a few days, no for chronic pain, because then you'll be on it for chronic long term, and that's, again, not acceptable. Now, opioids is, again, with the opioid crisis that we've had in our country and the pandemic that we've had over the years, opioids for me are, if they're not taken for cancer, then they're not indicated. They do have, simply put, cancer patients also have, nerve pain. They have their own share of back pain, knee pain, but they're cancer patients. A lot of times the tumor has invaded their body regions, and that's why they're experiencing that much of excruciating pain. However, if you have the bread and butter, herniated disc with arthritis, or tendinosis in your shoulder, there's no reason you should be on opioids. Opioids do have addictive properties, as we are all aware. They do have dependency, and they do have, a ceiling effect, where you might feel good when you take, let's say, 1 tablet a day of oxycodone, but then after that, your body will become tolerant to it, and you would want to take more. And, that's when it becomes a problem. That's dependency and addiction. And in the long-term run, it really masks the symptoms. It does not treat the condition. Remember, a lot of things we do in interventional pain is more to treat the pre-existing pain conditions, not necessarily cure, but treat. So in treating the problem, the arthritis may still be there, but you still will be. But if you're pain-free, then I'm treating the problem. Remember, arthritis, we said we're all going to have it at some point in our life, but what we need to do is treat the pain. Okay, because curing the arthritis will be surgical, but a lot of times we have arthritis in a lot of body joints. We're not going to go do surgically remove, each arthritic or enlarged bone in our body. It's not realistic. So we treat the pain. Opioid does not treat the pain. Opioid masks the pain and creates a lot of problems down the line. Now, also be very careful, because you would say, well, I had a root canal done and I was prescribed a little bit of oxycodone. I had some left over in my cabinet. I've taken them. I did the root canal maybe like a year and a half ago. A lot of times those medications are expired. That you should be, appropriately dispense those medications once you're done. If you have surgery, understandably so, they normally put you on it for a very few days again. So, but if you do have leftover, you go to the nearest pharmacy, you dispense appropriately of the medication pharmacist, and they appropriately dispense the opioids. But there's no reason you should be taking it for chronic pain, because it just leads to a downhill spiral, including addiction. And you know what? When patients get addicted to opioids, they also do get addicted to other things like alcoholism, and it just leads to other psychiatric problems that we definitely don't want to deal with, especially along with pain. So I think these are the two major things. The NSAIDs you're going to be very careful about, and the opioids is a no-no. We do have medications, neuropathic medications that we do give. We also use them very judiciously. They are not addictive, but they do have, a little bit of a sedative effect to them. So we are also we don't give opioids, but in terms of medications, nerve medications, like we might have heard of gabapentin or Neurontin, Flexeril, which is a muscle relaxant. We are also very careful when we give these. We never put our patients long-term on them, unless they've had, again, a severe condition, perhaps after surgery where they suffered a nerve damage and they're on it for a prolonged time. But for arthritic pain, again, we don't place our patients more or less, probably I would say a month to 2 months maximum, until we move on to the next step, which would be intervention.
So you talked a little bit about psychiatric. Does chronic pain have a psychological component?
Yep, it's. I feel some patients would tell me, I've never had any problems sleeping. I was never anxious. I was never depressed. But after my back pain, I can't sleep. I'm very groggy. It's taken a toll on me and people around me in my family. So yes, does chronic pain have an underlying psychiatric etiology that could contribute to the pain? 100%. In terms of chronic pain creating a psychiatric condition, again, like anxiety, depression, even cognitive issues like, memory loss, because you're just so engulfed in the pain that you cannot focus on your day-to-day activity. You're unable to keep track of, other things in your life. So that goes hand in hand. And that's why I tell patients, if you are in pain, you normally don't want to say, like patients that come and say, I've been in pain for 10 years. A lot of them are already in that realm of, they're already anxious, they're already depressed. And some of them have not sought psychiatric help. And if you're in that category, I would say there's absolutely no shame and no judgment in you seeking that, because it is almost like a spectrum. It's a spectrum of chronic pain symptom, that to be anxious, to be depressed, and it's not shameful to say, no, I don't need help, even though deep down you're disabled, you're unable to work. By all means, we do, and at our facility, we do have a wonderful psychiatric physicians that will be able to help you with that, and they're very well seasoned in that. So, psychiatric disorders such as anxiety, depression, a lot of patients feel that there's a stigma associated with them. And they feel that, I'm already on a lot of medications for my blood pressure, for my diabetes, for my heart, that I don't need to be on extra medications for my psychiatric condition. And sometimes that's not true, because a lot of times, psychiatrists will put you into psychotherapy, support groups. Sometimes all you need is to speak to someone. You're able to express yourself and perhaps share your experience with others that will be able to help you, or others that have been in the same situation and that were able to gradually, recover from it. So no shame at all in talking to your primary care physician or a licensed psychiatrist about fears that you have, and it's a normal part of chronic pain. I would say they go hand in hand, and I always tell my patients, we'll address your pain, but your mood, we need to address that with a psychiatrist. So yes, because, and believe it or not, sometimes with chronic pain, it leads to aggression, it leads to violence. So it's definitely something to be aware of, to know that it is part of chronic pain, to know that your outlook on pain will impact how you actually will feel in therapy, how you'll feel in your day-to-day, depression. So it's almost like a yin-yang kind of thing. So chronic pain causes a psychiatric illness, but psychiatric illness could sometimes re-exacerbate your chronic pain. Mm-hmm. Almost like a dual effect. They both go hand in hand. So yeah.
And finally, you really talked about the support system that we have here at the medical center, as well as your own doctor and the continuum of care. But how can I be proactive about my pain and my chronic pain? How can I help the physicians to make my life easier?
So I always, we're all part of a team, including the patient. Patients do have a say in their care. Patients, their feedback is of utmost importance to me and my team, the physical therapist, the occupational therapist. We always communicate through feedback. So you are a team player with us. Things that you can definitely help with your pain. Again, remember I told you therapy is active therapy, where you partake, you get to say, listen, today I'm going to do my home exercise program. Ideally, you want home exercise program to be done 3 times a week, non-consecutive days. So meaning not back-to-back days, just to give your body part, a joint, some rest. So proactive in doing your therapy, proactive in going to your therapy sessions. Don't feel discouraged. If in the first 2 to 3 sessions, you say, you know what, I don't feel a difference. A lot of times, your therapists want to get to know you. So in the first 1 or 2 sessions, they will do an evaluation. They will perhaps do very simple stretches or massaging or modalities. I don't want you to feel discouraged or say, you know what, my therapist is not really proactive. It's a way of us getting you eased into therapy. So I would say longevity of your endurance to go to therapy, it's a huge thing. At the end of the day, it's you that will be driving to the therapy facility and participating. And I'm not saying push through the pain. Very wrong idea for patients to say, well, I was in pain, but I had to push through my pain, even though a certain activity caused me pain. I just did it because I felt like guilty if I didn't do it. I don't want you to do that. Any activity or exercise that causes you pain, you let your therapist know. Remember, feedback and communication is key. They will modify the activity. Perhaps they may change it to something else, or they'll communicate it to me, the physician, and say, you know what, patient so-and-so is unable to handle therapy at this point. Could you help with some other means, such as injections or medication? So I think that's a big thing. Proactive, and also we talked about the psychiatric component. Being proactive about your psychiatric health. It's psychiatric/mental health is a huge deal. Okay, and at the end of the day, it's all about informed consent. It's all about you being able to participate in those, therapy sessions, groups, support groups, reach out programs. That's another thing. A lot of other times, with arthritis, since you're unable to move a lot because of, let's say, your pain in your knee, you're unable to go on your long walks or ride your bike, you do gain weight. So I would say dietary modification. Because pain a lot of time inhibits you from participating in physical activity. Watch what you're eating. It does have a huge impact also on pain because, our goal is to get you active again. That's another thing. Also, for smokers, smoking cessation, a huge deal. There are certain neurotransmitters in the brain that does get impacted by smoking, and smoking does increase your chances of being in chronic pain from simple pathology like arthritis or sprain. a non-smoker may be able to recover from a sprain of the shoulder, let's say, fairly quickly. Smokers, it takes them a longer time. Smoking, we know, has determinal effects on the lung and other organs, but also it does have an effect on your mood, and it does have an effect on your perception of pain and chronic pain. So smoking cessation, definitely. So these are all things that I feel, go hand in hand. At the end of the day, we tell the patient, before I schedule for a procedure, send them to therapy, give them a medication. We always explain the risks and the benefits. We always see if it fits their schedule, if it fits their lifestyle, but to be able to take that medication that might make you feel a little dizzy, or go into therapy 3 times a week versus 2 times a week for given your work schedule. So, proactivity, and I want you to always, we call it partaker in decision making in your care. You're the best person that knows who you are. You live with yourself on day-to-day basis. So communicating how you feel to your physician, how you feel to the team is a huge part. And, coming up with a game plan is of utmost importance.
Wonderful. And Dr. Hannah, thank you so much for taking the time to speak to us today. If you'd like to schedule an appointment with Dr. Hannah, please call our coordination line, which is 201-225-7130. And to learn more about the foundation, please visit us at newbridgehealth.org. And thank you again, Dr. Hannah.
Thank you, Rosemary. It was a pleasure.
Take care.
Bye-bye.